Welcome to the educational recording for the topic Assessment and Intervention for Gait, Strength, and Balance Impairments. The Catch Roll Falls program is supported by the Nebraska Department of Health and Human Services Office of Rural Health through the Medicare Rural Hospital Flexibility Program. The content of this presentation is solely the responsibility of the presenters and does not represent views of our funding source. I am Dawn Venema. Vicki Kennel and I form the UNMC Catch Roll Falls team. We are both faculty in the College of Allied Health Professions at the University of Nebraska Medical Center. I'm a physical therapist, and I bring clinical perspective of fall risk reduction to our team. Vicki is an industrial organizational psychologist, so she brings that unique viewpoint to our team with expertise in quality improvement and organizational and team science. The educational objectives for this recording are to conduct a gait strength and balance test as part of a thorough assessment of fall risk, and identify appropriate interventions when impairments in gait strength and balance are identified as risk factors. The Centers for Disease Control has a nice framework to follow for fall risk management of older adults in primary care settings. It is called the Stopping Elderly Accidents, Deaths, and Injuries, also known as STEADY initiative. STEADY recommends 3 steps, the first one being screening, where you are trying to get a quick snapshot of whether or not a patient is at risk for a fall. The topic of screening is covered in another recording on our website. Steps 2 and 3 are assessment and intervention. They are what follows if a patient screens positive for being at risk for a fall. Assessment is a step to take where you are trying to identify specific risk factors that place that patient at risk for falling. In other words, why is that patient at risk? Impairments in gait strength and balance may be one of those risk factors. And then intervention is the step where you take action to address a risk factor. The CDC has a nice algorithm that walks you through those 3 steps in more detail, and the link on this slide will take you to it online. Here is a picture of the algorithm. Here, I'm highlighting those steps of assessment of specific risk factors, which then lead to intervention for any risk factors found to be present. And here I'm highlighting the specific risk factor of gait strength and balance impairments to show you that it is one of many risk factors to be assessed, as well as suggested interventions that follow if the patient is identified as having concerns in this area. I'll go into these more in depth on the following slides. There are 3 standardized tests that the STEADY initiative recommends to assess gait strength and balance. You might choose to do all 3, or you might choose to do 1 or 2 of them. All are pretty simple and quick to do. The CDC provides links to instruction sheets and demonstration videos on the STEADY website, and those are all linked for you here. These instructions can be printed off and used as provider or staff education, and the videos are also really great staff training tools. The first test is the timed up and go, or TUG. This is a mobility assessment used to identify problems with gait and balance. The patient sits in a chair, stands up, walks 10 feet at a normal pace, turns around, walks back, and sits down. They can use a device like a walker or a cane if they typically do. Their performance is timed, and a longer time, meaning slower performance, indicates a worse performance. Taking longer than 12 seconds to complete the TUG indicates increased risk of falls and would prompt intervention. I have also seen research recommending 14 seconds as the cutoff score. If you think about it, more people are going to test positive or fail the test with a 12-second versus a 14-second cutoff score. And I believe the CDC recommends the 12-second more stringent criteria to ensure no one is missed. More people are going to test positive, so that cut point is going to have increased sensitivity. The intervention that would follow if a patient is indicated to have impairments of gait strength and balance is generally exercise. That's generally low risk and high reward. And so I'm sure the CDC was thinking that it would be better to go with that lower cutoff as a result. The second test is the 30-second chair stand. This assesses leg strength and endurance. The patient sits in a chair, crosses their arms, and stands up and sits down as many times as possible in 30 seconds. You count the number of reps they complete and compare it to normal values based on their age and sex, and the instruction sheets has those normative values. The third test suggested is called the 4-stage balance test. This assesses balance in successively more difficult standing positions. Some of you may know this as the Romberg and Sharpen-Romberg. It involves having them start with their feet side by side and holding that position for 10 seconds. Then they take a slight step forward with one foot and hold for 10 seconds. Then they get into a tandem position or heel to toe position and hold that for 10 seconds. And then single leg stance, standing on one leg for 10 seconds. They can hold onto something while assuming the position, but then must let go while you are timing. If they cannot make it through 10 seconds with a tandem position, they're considered to be at risk for falling. I want to share some practical tips for conducting these tests. First, I want to emphasize you do want to promote safety during the performance. These tests are meant to challenge people's balance and mobility, and so you want to keep them safe while they're in your clinic conducting these tests. You want to stand next to your patients during assessment. You might want to consider using a gait belt, so that way if they start to lose their balance, you have something you can grab onto besides their arm or clothing. If a patient is known to have one side of their body that is weaker, so for example, if they've had a stroke or maybe surgery on one of their legs, you want to guard on that weaker side, because if they're going to lose their balance, it's more likely going to be towards the weaker direction. You don't want to use a chair that has wheels on it for the timed up and go or 30-second chair stand. And it's also a good idea to have that chair be placed up against the wall so it doesn't tip when the patient is getting in and out of it. I also recommend conducting these tests as easy and as routine as possible. So find a standard place in your clinic that these tests can be conducted. You might go ahead and measure out the 10 feet for the tug and leave those marks on the floor as one example. And that way your staff doesn't have to do that every single time. Have a standard place to keep equipment needed, such as a gait belt and a stopwatch, and consider what chair you're going to use. A 17-inch height chair is recommended for the 30-second chair stand because you're comparing the performance to those normative values. And so you need some standardization there. If you don't have a chair that's exactly 17 inches high for the seat height, find something close and try to use the same chair every single time, especially if you might want to do this on repeated visits so you can see how they change from visit to visit. If you find that it's simply not feasible to conduct these standardized tests, at least observe a patient's movement patterns and look for some clues that their gait strength and balance are impaired. This alone might be enough for you to decide that you want to refer for some intervention of this risk factor. So for example, do they have to use their arms when they get out of a chair, or do they reach out and touch walls or furniture while walking? Lastly, try to develop a workflow. Figure out who in your clinic will be responsible for conducting these tests with your patients, and how are the results of those tests going to be communicated to other people who need to know. So for example, if a nurse or medical assistant is conducting these tests, they're going to need to route that information to the provider so the providers can proceed with intervention if needed. So what do you do with the results of these tests? If a patient fails one or more of these tests, one of the first things you should consider is whether or not a patient should be referred to physical therapy for a more thorough evaluation and provision of an individualized exercise program, as well as potential assessment for the need for assistive devices for walking. Another option is an evidence-based community exercise and fall prevention program. The main difference between PT and a community-based program is whether or not an individualized program is needed and individualized attention. The community-based programs are going to be more likely delivered to a group of individuals at the same time, and the person delivering those may or may not have as much education as a physical therapist does. So if the patient is borderline, like they barely fail one of the tests, a community-based group exercise program might be enough. But if you're concerned about that patient's safety and their potential for falling during exercise, or if they have a really complicated medical history, working individually with a physical therapist is likely the way to go. Now, if your patient passes these tests, you could still consider referring them to an evidence-based community exercise program if it's available in your community. A good reason to do this would be to help them maintain their strength and balance and mobility to prevent them from becoming at risk for falls in the future. I want to share some additional notes about physical therapy referral. You should realize that some physical therapists have specialized training or board certification through the American Board of Physical Therapy Specialties or the American Physical Therapy Association. These are national professional organizations related to PT in the US. So some certifications that you might want to keep an eye out for are board certified geriatric or neurological clinical specialists. These people are going to have some specialized training and skills in working with older adults and people who are at risk for falls. They will have passed a board certification exam in this area. Other examples are PTs who are a certified exercise expert for aging adults or hold a balance and fall prevention credential through the American Physical Therapy Association. Now, this isn't to say that people who don't have these extra credentials can't be used. It's just that if you do have PTs in your community that have this extra training, those would be who I would recommend that you send your older adults to. Otherwise, there are a lot of physical therapists that have a great deal of experience and skill and knowledge about these issues, even without this extra training. So rest assured, if you were to send your patients to a physical therapist, even without the extra education and certification, they likely would do a very good job with your patients. Here's a slide about community-based exercise and fall prevention programs. I've got some examples listed on the slide here. So for example, Tai Chi, moving for a better balance, and you'll notice that one's even trademarked. That's because many of these programs are standardized. The people who deliver these programs have been trained in how to deliver them. They're structured and follow a specific curriculum. So you might want to look for some of those specifically in your community or surrounding communities. I have a link on the slide to the National Council on Aging that provides some additional details about the examples listed on this slide, as well as some additional programs that you might consider. Now, how do you find these programs? Your area agencies on aging might be a good resource that would have some information on whether or not these are available in your area. Local health departments would be a potential resource as well. You could talk to your local PT clinics because those PT clinics may be referring patients to these programs after discharge from PT, or those PT clinics might offer programs like these to people who've gone through rehab but need continued work to maintain their progress. Local fitness centers such as the YMCA might be an option, and even churches or other community organizations can be a resource. I also want to mention the community-based exercise programs don't necessarily need to be one of these named standardized programs. Any type of exercise program that is offered that is geared towards older adults in your community might be a good fit for your patients. In summary, I shared information about how to assess gait strength and balance using standardized performance-based tests like the timed up and go, 30-second chair stand, and 4-stage balance test. These standardized tests allow for comparison of published values to help you determine whether or not a patient is performing well in this area or not. In the absence of using a standardized test, observing their mobility for unsteady gait or difficulty rising from a chair offers you some clues that they have impairments in this area. Interventions for this risk factor include referral to PT, especially when a patient has significant impairment, complicated medical history, and needs one-on-one attention and individualization of a program. For patients who aren't as impaired, or for those who don't have impairments of gait strength and balance, but you want to help them maintain their mobility, community-based programs usually provided in a group format may be sufficient. This slide has a number of resources related to this topic. Thank you for listening. This concludes the presentation on assessment and intervention for gait strength and balance.